Dr. Wahid for this presentation. I feel honored to participate in this symposium. And at first, I would like to say that I personally feel privileged, and we all feel privileged to have this machine at MRC. We have come across, I can say, a lot of challenging and interesting cases over the past year and a half. I'm going to talk about the female PET-MR oncological applications. Of course, this has already been mentioned. I just want to say that to highlight again that the integration of MRI in this hybrid imaging tool is of utmost importance because we are not doing a simple body survey. We are applying a state-of-the-art multi-parametric MR study that is customized for each patient separately. So accordingly, we are applying or using high-resolution MR images, diffusion-weighted imaging, perfusion studies, and dynamic contrast studies, together with spectroscopy where and when it's needed. This helps us in entering the era of radiomics, where we are applying or using quantitative imaging features rather than relying only on the morphological criteria or benefits of imaging. Together with, hopefully, we will enter into the radiognomics, where we are applying or correlating between the different imaging features of tumors and their gene expression. Now, as my colleagues and Dr. Yasser mentioned, that we are not fusing images. We are the images are acquired simultaneously and they are co-registered, and this is what helps us to combine the data more accurately, voxel by voxel, and accordingly this helps us for better and more accurate characterization of the tumor heterogeneity and applying the multi-parametric hints which help in predicting the clinical outcomes of different lesions. Now, triaging the oncological cases that would benefit the most from a PET-MR study. Now, I guess you have all known that this is considered a one-stop shop examination that helps us in not only staging, local staging and characterization of lesions, but also covering the whole body with a high-resolution study. Now, we have already mentioned these body applications, so I will highlight only the female, the breast and female or gynecological malignancies. Also, I'm going to go over this rapidly. You have already known these points, but I would like to say that what we are actually doing at MRC is that we are tailoring the MR study for each patient. Again, we are not only doing a whole body survey, we are selecting the most crucial and most important sequences and data that helps in the accurate characterization of the lesions, whether it is for local staging or for the assessment of the patient as a whole. Now, I guess we all know the importance of MRI in the assessment of breast lesions, namely breast cancer, in staging of breast cancer, because we are integrating not only the high morphological imaging sequences, but also we are integrating the functional MR tools, including diffusion, perfusion, and spectroscopy, which helps us to provide the morphological data, detecting the areas of increased or impaired blood flow, areas of altered cellularity, and to assess the cellular integrity of lesions and surrounding breast parenchyma, together with the metabolic assessment based on the alterations that happen as regards the choline and lipid relations. Now, integrating or performing a PET-MR study adds an edge to this because there is a certain degree of overlap between benign and malignant lymph nodes. PET-MRI has given us an edge and has given us more confidence in assessing the nodal relay of breast and other gynecological malignancies, together with the added value of the whole body coverage. Now, I'm going to show you examples of some of the cases we have done. Now, this is a case of invasive ductal carcinoma that was coming for initial staging. We can see that in the right breast, there are two focal areas of FDG uptake. These are the combined or the fused images incorporating the PET with the MRI, which helps in accurate localization of the lesions and showing us the multifocality of this breast malignancy. This is the above images are of the right breast and the lower images are of the left breast, showing no abnormalities in the within the breast parenchyma. Of course, as I mentioned, we perform a tailored, dedicated MR study of the breast that definitely includes dynamic contrast study, so as to be able to handle or to show the handling of the different lesions for the contrast. For this case, the patient had already in the first presentation metastasis along the neurological axis, including the brain and within the spinal cord, which was easily delineated through the MRI and furtherly supported by the vivid FDG uptake. And then this is another case of a left breast invasive ductal carcinoma that had no evidence of distant metastatic disease. She was a candidate for neoadjuvant chemotherapy, and this is her initial study prior to the chemotherapy, where we can see the sizable lesion seen at the lateral aspect of the left breast. The lower images are showing the diffusion weight. Of course, the images seen in the middle are the fused MR PET images, and then the lower images are of the diffusion and ADC, the diffusion weighted images and the ADC map, showing the increased cellular packing appearing as an area of low signal amidst the breast parenchyma that shows higher signal intensity. These are the set of images taken after chemotherapy, and we can see there is a marvelous response on the scale of the size of the lesion, the disappearance of the uptake on FDG, and also the disappearance of the abnormal diffusion behavior on diffusion-weighted images. This is another case of breast cancer that was treated 30 years ago. She was presented with vague abdominal pain. Her CT study revealed ascites and smudgy pelvis. Now, I guess we all know that the CT is limited when we are talking about pelvic lesions and pelvic malignancy and delineation of the different pelvic organs. So we can see in this case that there is abnormal FD. This is the PET 3D image. We can see that there is abnormal, patchy, and localized FDG uptake within the abdominal pelvic planes. These are the fused images showing us the sheets of abnormal tissue showing FDG uptake consistent with peritoneal and omental metastatic lesions. And furtherly, we can see there is a clumping of vivid FDG uptake seen at the right hemipelvis, which was an ovarian malignancy. So this patient developed ovarian cancer long after her breast cancer, which was in her first presentation metastatic to the peritoneum. These are furtherly dedicated pelvic images showing the PET, the T2 FATSAT images. Then we've got the fused PET MRI, T2 weighted images, and last but not least, definitely we have the diffusion and the evident cellular packing seen as regards this lesion. Then we have the peritoneal nodules that were clearly delineated and spotted. Together with, in this case, we have the patient also had hepatic parenchymal metastatic deposits, which were hypoperfused and appeared hypo-enhancing on the post-contrast images. The patient also had bone mets, as we can see within the pelvic osseous structures. Then we came across a case of metastatic breast cancer that was on chemotherapy. She was coming for follow-up. And what was standing out in this patient was her agonizing back pain. She was treated, her breast cancer, the primary lesion was treated with a flap reconstructive surgery seen on the left side. This was her PET-CT. there was an equivocal lesion that showed a limited PET FDG uptake at L2 vertebra. But then we can see she was referred for this PET MR study, which showed more vividly the lesion. Now, we perform the marrow characterization sequences in MRI, which plays an utmost role when we come across cases with equivocal bone lesions. Is there metastasis or not? Because sometimes the patient may have osteoporotic changes, may have blood disorders that alter the appearance of the marrow, but they are not actually metastatic lesions. Now, we can see here in the first image down, we have the water-only sequence that shows us that there is a lesion within L2 vertebra that is of high signal. It has high water content rather than lipid content. The T1 in-phase and out-of-phase sequence shows the drop of fat signal in the rest of the bone marrow, leaving out this lesion at L2, furtherly supported by the diffusion restriction, the hyperperfused state, and then again, as we have mentioned, the longer acquisition time of PET MRI helps in further deposition of FDG and further delineation of the uptake. Furtherly, this patient showed metastasis in the liver. This is another case of lobular breast cancer with inconclusive vertebral marrow lesions on the bone scan. Lobular cancer is known to be one of the cancers that is FDG is not that sensitive to it. We can see that there are spotted lesions at the lateral aspect of the left breast. This is the dedicated MR study, including the dynamic contrast enhanced study showing the type 3 time intensity curve, diffusion, restriction seen within a patch of architectural distortion and non-mass enhancement. Now, the fused images here show that the area of architectural distortion is far more sizable compared to the focal areas of FDG uptake. So we can say that there is a mismatch between the FDG uptake and the actual spread or the actual size of breast involvement. Together with, as we can see here, there is the involvement of the axillary lymph nodes. As I mentioned earlier, PET has given us an edge when detecting, when confidently calling out for metastatic lymph nodes. As we can see here, we were confidently ruling out any metastasis attributed to the appearance of the in-phase, out-of-phase, and the PET FDG uptake of the marrow along the spine. And then let's head on to the PET MRI in gynecological malignancies. Again, we know that MRI is of a superior role.
2 minutes left.
Okay. When it comes to characterization of gynecological lesions, staging of malignancies, and in follow-up after neoadjuvant chemo or radiotherapy or after different surgical approaches. Then adding PET to it has given us an edge where we combine the high FDG avidity of tumors to the enhanced MR delineation of the primary together with the signal characterization of the lesions. Again, I'm talking about the importance of combining PET with MRI that raises the sensitivity, specificity, and diagnostic accuracy of nodal disease. This is an example showing us a case of cervical cancer. We cannot see anything on the CT. Delineation of the lesion is extremely difficult. Of course, we can see the uptake on the PET, but then again, the MRI helps us in further assessment of small lesions, their extent of involvement, and their extent of spread. This is a case of a known case of metastatic ovarian adenocarcinoma that was pathologically proven to be a high-grade serous carcinoma. This is a comparative study with one prior to chemotherapy and the other study following her chemotherapy. Now we can see the marvelous response to therapy where all those lesions that were previously delineated have subsided or have resolved. Furtherly, you can see the clumped lesion infiltrating the uterus in the previous PET-MR study that has completely resolved with the preservation of the normal appearance of the uterus in the more recent study, or the post-treatment study. We can see the previous study showing the clumping of the omental cake and the lesions, peritoneal lesions spreading around the hepatic capsule that also resolved on the post-treatment study. We can consider PET-MRI a frontier in the hybrid imaging because choosing the modality which is best for each patient is crucial. It is considered a one-stop shop examination that is less time and, of course, money consuming for the patient. It answers as much as possible accurately the questions that are asked by the clinicians. It is overcoming the pitfalls of PET alone. And we are dealing with patients through a holistic approach, dedicatedly performing the MR study for each patient separately. Thank you very much.